I'm Terry Simmons, and you're listening to KTVS3's DocTalk. This is the place to be to hear informative, forward-thinking, solution-based discussions about what contributes to our mental health and our overall well-being. You can download a new episode every other Wednesday morning wherever you listen to podcasts. And joining us today is Dr. Catherine Vanderloos. We're going to be talking about menopause and how it can affect your mental health. And a lot of things, we were just talking before we came on, we've discovered we're just really going to, in this episode, pick it apart and start from scratch and talk about what menopause is, how it affects our mental health, how our mental health can affect menopause. There's so much to talk about. Thank you for being here.
Thank you.
So where do we start? Let's talk about, do we need to define menopause?
Well, we might need to do it again. We've done it before. And so it's officially when you've not had a period for a whole year, or if you've had surgically removed ovaries, because it's the absence of ovarian function. So either it's physiologic or it's surgical. And it's, the loss of estrogen, the loss of testosterone, the loss of progesterone, and they all happen at different phases. So usually I think of the testosterone, which is male hormone, and people forget we all have a little bit of it, and sometimes people really miss that, and some people never miss any of them. So that's where it gets to be a little tricky. So first you lose the testosterone, so you may have some fatigue, you may have some fogginess, but you're also in the throes of life. You've got kids running all over, or you're worried about them running all over. You're going through all kinds of life changes. It's another chapter. So ovulation may go away or become very infrequent, which leads to periods either getting lighter and off into the sunset, which is what we hope they do, or getting heavier and closer, and then there's something we can do about it. And then, of course, usually about that time you start to notice some hot flashes or night sweating or vaginal dryness, which causes pain, and those are low estrogen things. And so you mix it all up. You have to kind of peel them away and see what are the main symptoms, what's bothering you the most, and that's what we attack first.
Okay. Is there anything else, like physically, like your skin? Does your skin change? Does your hair change?
That's
anything
a very
like that?
individual thing. Skin, sometimes it changes, and so replacing the hormones, the patients will say they really noticed it. Now, sometimes I had one patient who had very dry skin, and one of the side effects of testosterone is oily skin, which is what we don't want to have the patient have. But she says, no, I don't want it fixed because I'm so much better, leave it alone. So that's an individual thing. Some of the hair drives everyone crazy, us, the dermatologists, because there's so much, and it takes so long to see a change when you start to implement treatment. So one of the things to always check for women is to check their thyroid, because thyroid disease, low thyroid, is more common in women, more common as we get older. So it's important to check your thyroid functions, and not just the TSH, which has been a gold standard for a long time, but to check the free T4 and free T3, because sometimes a small replacement can make a huge difference in some of the symptoms.
And it's not just age.
No, it's not just age. It isn't. And I never like that phrase, because, what is age and what's appropriate for that age group? The only time I get annoyed with that is when, they ask for what's the risk factor, and it's your age. So your reward for living older is you get all the risk factors for everything.
True, that's true, but I guess it's a pretty good trade.
It's good trade-off, yeah. That's right.
And just because you're at risk doesn't mean you're going to get it.
Exactly.
So you can overcome those risks,
right.
And there's a lot of positives to that.
Well, and the hormone replacement, it's been up and down over the years. When we only had a couple of options for the estrogen, we knew at that point we didn't have thyroid, we didn't have cholesterol medicines, we didn't have bone densities or bone medicines, and we knew that estrogen would, people would start to lose bone density, and then we put them on their estrogen and they did great, and then as we started to taper them off, they would start to lose their bone density again. So it does a lot, and testosterone will help with bone. These things are all multifactorial. And mental health is a big part of it's very physical. I always say the parts of depression are a very physical feeling. And so when you can't get off the sofa and then you're depressed because you can't get off the sofa, that's a very physical thing. So you have to kind of tease these things away. we used to think it was just sleep deprivation, which really can be a problem with hot flashes at night. The hot flashes keep your brain awake even if you're not awake. So you don't get that restful REM sleep. So I love the little watches that we have now. We can look at I'm a number person, but I also try to not treat a number. So, but you can really see a difference in someone who's sleep deprived from low estrogen and replace them, and then you start watching their REM and it starts to build up and they feel so much better, and they wake up refreshed rather than more tired than when we went to bed. But it turns out also there are very nice articles about showing the decrease in estrogen makes people more prone for depression and anxiety. Now, who's the chicken, who's the egg? The ones who have had issues may have it more. But you still have to treat the whole patient. And, and again, I'm speaking of life changes, divorce, job change, empty nest, even good things can really rock your boat. So I think it's always important. I really believe in checking numbers and getting hormones replaced adequately if it's indicated, if things are bothersome. That's the operative word for if you're having some hot flashes but it's not bothering you, don't do anything about it, just kind of watch it. If it becomes bothersome, then you do, and you're allowed to do something about it. I think it's a time of empowerment for the patient. But we also have to think about antidepressants, anti-anxiety. I'm a big one for counseling. I think that helps immensely. And counseling and the medications, each by them, they're better together than separately. If you can, not have to use medications, great, that's wonderful. If some mindful meditation will help you kind of refocus and not be internalizing all the anxiety of the world. I mean, you could,
yes.
if you watch the TV too much,
you can.
But you see so many things, and you feel so bad, or you feel you can't do anything, about it. So I think you really have to look at the whole picture.
Mm-hmm. And that is a good point. Sometimes we'll watch TV and there's so much that we can't do anything about. And then you can even turn off the TV, and then you'll find that you're bringing more into your life that you can't do anything about. You'll attract even more because you'll be in that mind state of there's so much I can't do anything about.
Exactly.
So my child is doing this, I can't do anything about it. Or my body's out of whack and I can't do anything about it. So mindfulness really does help.
I think it's a great thing. And whatever works for you, if praying the rosary. I grew up as a Catholic, and we would, that was my mother or my grandmother. My mother used to have a St. Anthony statue, and he had one leg, it was 3 legs, and he had one leg broken off. So if she needed something, she'd put him on his head. So, and it always happened, It
always happened,
It worked out. Her little statue. So when we cleared her house, I wanted the little statue.
Oh, I would want that too. That would be meaningful.
Yeah.
Do you think we're moving into that, whether it's because of coming out of the pandemic or not, that we really are paying attention that it's individual, and if something is wrong with you, it's wrong. It's okay to talk about it, to ask about it.
Right. And I think that's a big deal. I mean, I think with COVID, we all were internalized, and that wasn't a good thing. We isolated people. Social isolation is the worst thing for anybody, no matter what age. Yeah. And I think it created a lot of issues, or maybe it just brought them out, so you were able to cope, but then this just threw you off. So yeah, I think over the years, it's been something that it's okay to talk about it. Again, I always think about my mom. She talked about PMS, and she had a terrible time with it, but she said, you never talked about it. People would lock you up. And she said, you girls live in a good time. And this was some time ago, So I encourage patients to talk about it, and I think support groups, and even with all the craziness of the COVID thing, everybody got used to using the podcasts and Zoom and stuff like that. And I think that's been a wonderful thing. It lets people out of their house. I mean, I do knitting podcasts all over the world, so I love seeing what other people are doing in their country and all that kind of stuff. And that helped me through when we were first locked down, because, man, you're in the house. But I did almost get a PhD in knitting, so my expenses on my hobbies went up a little bit. So. But I think it does empowered people. I think it's caused a lot of craziness that sometimes people don't even realize that loss of control. And then, jobs change, and, working from home as opposed to going, to the office, you miss that camaraderie, although you don't miss the commute. So a lot of people, that's an hour time that you can use something productively or do something for yourself.
Yeah. And so it's easy to spiral into, this is different, this is wrong, this is scary, instead of saying, wait a minute.
Yeah. Exactly.
What is going right here?
Yeah.
It seems like we're coming out of a lot of things that went right, like people not wanting to go back to the office, wanting to be hybrid, where at first they were like, I feel cut off, and then it was like, well, wait a minute, I'm more functional here. Well,
it is very interesting. It's created a whole world which I don't think anybody has an answer, because it's never been like that. Oh, there's a novel thought, But, you learn to be more efficient, so you got by with fewer people. Well, that's not good for the people who needed that job. On the other hand, maybe they were channeled into doing something else that they really loved, or something new that they'd always wanted to try. And I think that's part of the age group that I treat as you're entering into menopause and going through it. It's a different chapter, and you're allowed to focus on you more. You may still have family dependence, but it's a little different. And so I think I always tell people, if something stops, maybe it's time to just do something that will just give you a lot of fun. Try something, take some courses, or spend some time, donate some time, in something that you might like to teach kids, or, stuff like that can bring goodness to people.
Absolutely.
Yeah.
And do you find that has changed over the years, that now more doctors are saying more of that kind of stuff, like, wait a minute. And first of all, let's back up. I wanted to ask about when you talked about how sometimes we hear, well, that's just the way it's always been. We've always done it this way, or my family's always done it this way. My mother had it, my grandmother had it, I have it. And some people, do you find that resistance?
Yeah, it is. And so, well, I guess it goes both ways.
Yeah.
Because for so long, women were never allowed to say anything. So the fact that you could say something made a difference. The world, we're pretty maternalistic, so what Mama told us was true.
Yes.
And most of the time it was pretty right, considering. She may have come about it a different way.
Yes.
Or she would say, look, I had to do this and this, but you don't have to. You're a smart girl, you can do that, And so they empowered us. And I think some people, they may not have family to have that support, or, information. So that's what we should offer. But I've always offered that, because I could see that, medicine is you need the whole picture. It's not just the physical part. And so many of our diseases, if you look, there's something going on that's stressing them, or they're unhappy about, that if you don't fix that, you're not going to fix their blood pressure or their blood sugars sometimes.
Yeah.
So it's important.
And you feel like your patients or even anyone you're talking to, in your circles, everywhere, like people are more open to tracing that back to, wait a minute, I just want to sit for a minute, relax, and find out, wait, I can trace this back. I'm doing this.
I think a lot of people are, but there's some that don't want to know.
Don't want to know.
No, don't want to know.
Right.
And you better not bring it up,
Yes.
or you just know you've hit a bridge, we'll take that another day, kind of thing, or it's too painful.
Yes.
And some of the painful things that are out there that should have never been going on are coming out, and people are allowed to talk about it, and and that's huge. That's
really
huge.
Is. Yeah, and there's some things that people are discovering that they buried and didn't know.
Right.
That this happened to me. Oh my goodness, I blocked that. And
and I always talk
traumatic.
to people about anxiety and depression, because I say we carry baggage with us, and we may not even know what it is. And it may have something 20 years ago, or as a child, or or just sometimes you don't remember them because they're so painful, and the things start happening, and you got to figure that out.
Yeah.
So.
Yeah, you really need to figure that out.
Yeah.
But ask for help with it. You don't have to do it by yourself, and I think some people feel like they're just all alone in that.
Right. And if you don't know, if you can't help them yourself, then get them referrals. And I do referrals all day long. I have a list of my counselors that I use. If they don't have an internist to kind of look over them, because a lot of folks have multi-medical problems, and it's not something there's so many new blood pressure medicines. I don't know. I don't want to know. It's like, I don't know because I don't want to know. That's not a good attitude. But I mean, I think that's the reality, and there's really fine tuning in many of these things. So, or get them to ask, or if they're starting to show some kidney issues or liver issues, and obesity is such a big deal. And, I'm told the most common source for liver failure these days is fatty liver, and it's not alcohol related, which we always thought it was alcohol.
We always did, yeah.
It's obesity. It's just like the people with lung cancer that never smoked a day in their life. We're seeing those. So we have to pay attention.
And do you find that people, when they come in, and you must have to quickly assess, because a woman going through menopause, and she may be carrying the load of so much that we know women do in general. Not that men don't, but women, we know a lot of focus on the things that women do. When they come in and maybe they do have that, all of these things we just mentioned, you don't know. A woman has something that locked in her history. She doesn't want to know.
Right.
She is feeling isolated. How do you break through something, even if you don't know what it is yet? How do you master that?
Well, there's a few things. One, we have a screener for menopausal symptoms. And so, do you have any? Are they mild? Are they severe? And the patients will say, I checked off every box and I'm severe. I had no idea. I'm like, you kind of did, but you didn't want to know. But I think that's I'm very visual, so that's an easy thing to check. Or, for example, with weight loss, there's so much binge eating out there. And really what it is a form of ADD. And if you help them with their binge eating to help them lose weight, you correct their concentration and their focus. And I've had people in tears because they said, I never knew I could do this.
Yeah.
It's life altering. And so, those are little screeners like that. A lot of it you just can tell. When you walk in the room, you start talking to them, what they're comfortable talking about, or what they're focusing on, what they're talking about, and sometimes you have to bring them back in a little bit, or you just have to listen. And I think listening's a big deal.
It's huge in everything, I think.
Yeah.
Just that deep listening. And have you had conversations before where you've listened the whole time, really haven't said anything, and then they're like, oh, this was great talk, thank you so much. If you let someone talk long enough, sometimes they'll get to where they'll hear themselves go, wait a minute. They just need permission sometimes, in a safe place, which is what I think you provide for them. Just a safe place to come and just
they could just
unload.
say anything on the wall. I tell them it can hit the wall. It's, that's what you need a counselor for too. It's your wall. You can say anything because you need to get it out and figure out what's going on. We always have talkers, and sometimes you have to reel them in, kind of thing. Or sometimes, you try to help them along the way, and they're determined they know what's right, and they're going to do it, and that's their right. And I really believe in patients' rights. And when that starts to happen, I start to say, well, it's America. You can do what you want. Like, if you don't ever want to have a mammogram, I think that's medically not right, and I will write it in the chart and tell you that I offered it and you declined it. But it's your right. But my nurse also knows when I start to say it's America, we're wrapping up. It's because you're not going to accomplish. I don't think badgering people, or you can give them a prescription, but if they're not going to do it, if they're not even going to fill it, let's not waste the energy. Let's do something else about it.
Right. Yeah. Which is a good thing on the other side, to just go in open and just hear everything that's available. Your doctor is just like, you're not going to cram it down the throat and say you have to do this.
Right.
But it's like, I'm telling you everything. This is available. Everything is here available to help you.
Well, I'm always surprised, even in 2022, that people don't know how much is available for being treated in menopause.
Yeah.
We have, for some of the vaginal dryness, which causes trouble, we have a pill, we have 2 inserts. I have my Mona Lisa laser. All of those work so much better than just the vaginal cream we had for 50 years.
What's the Mona Lisa laser?
Mona Lisa laser. That's my favorite. She was my first machine. But what it does is it drills, it's so microscopic you don't even feel it inside the vagina, but it drills little holes. And in the healing process, even within days, you start to feel, you start to have less pain, less dryness, and it's the kind of thing, you have sensations you didn't even know you lost. And there's 3 treatments, each 6 weeks apart. So you're about 70% better on the first one. And so the second one gives the lubrication back and just more function of the vaginal walls. And then the third one makes everybody last for a year. and it was developed in Italy, actually probably 20 years ago now, and it's very, very popular over there. It took a while to come across, and then I didn't look at it because it's a very expensive machine, so I didn't look at it for a while, but one of my patients had it done, and it was so impressive how much it did for her, and so I felt like if I didn't offer it, it's not meant for everybody, but it's certainly an option, and it's a big option for some of my the breast cancer patients who can't use a lot of stuff, especially early on, and they're on anti-estrogen medicines, which really make that poor vagina get very dry and painful. It changes, your bladder function changes, stuff like that, and so it can make a big difference for them. So that's important to know. So those are all. I mean, we had vaginal cream, and we had one brand. And it was never generic for 50 years. I mean, it was a long time. I shouldn't say 50. It's probably 30. But even now, if it's not covered by insurance, they'll charge you $300.
Goodness.
And so we all have been in uproar about that for a long time. You can do compounding things, that helps sometimes. But we have all these other options that people didn't know. And so, in the estrogen world, we have pills, patches, sprays, pellets. Testosterone's another story because the FDA has never approved that for women. But we've used it off-label because we have good studies showing it's important. You just never can quite get it approved.
Is there a specific medical reason for that? Why testosterone?
Well, I think it's been a problem since the Women's Health Initiative. And, hormones were so banished, and it just wasn't great. It just wasn't great science. If you start studying women that are 60 and the symptoms start at 50, you're going to get very odd, like heart disease. You don't improve heart disease. Well, we knew it improved for quite a few people, but if you're not studying her until she's 60, either she has it or is never going to get it. So there were just a lot of flaws. I mean, I think it raised a lot of issues. It also was at a time when they kind of gave the hormone replacement company that actually donated the medicines a really hard time. And the problem was, it was the only thing available. People forget, there were no patches, there were no sprays, and we talk about transdermal because it doesn't pass through the liver, so there's less issue with clotting, which the pills do, although really the issue is, one, smoking, nobody should do, and then two, we've learned a lot more about clotting factors, so some people should just never use estrogen. They have certain, like Leiden factor or different kinds of things. So I always ask about family history of early heart disease and clots, and some of the younger women, when the first moment they started taking birth control pills, they got a clot. Well, it turns out, and we just didn't know at the time. So, excuse me. So getting back to why, well, along that, so they weren't going to approve any kind of hormone, and there was a nice little tiny testosterone patch really being used for bones, but man, they were not going to approve any hormone, just flat across the board. And so along the way, we had one company that was really very promising, and they had 10,000 women in their study. They will approve a med for a guy with 500 in a study, and they've got, I always say they have 50 kinds for the boys. But they came back to that company and said, no, you don't have enough safety data, you need more people. And they'd already invested millions and had 10,000 patients. So they just pulled it. They just gave up and stopped. And that's an injustice for women. And that's, one of those deals where lacking science because you lack money, but that's not always the whole answer. And it's sad because there's so much to us.
Yeah, we mentioned that in a previous episode where you were here. Remember, we talked about that it's not until recently where now there's been funding promoted to studying women.
Right.
That it just hasn't been done.
And see, how crazy is that? Because guys and girls are not the same. Now, there's a novel thought. And heart disease, one of my friends from college is a big heart disease expert in women. And, they just present differently many times and have been ignored. And, it's like maybe they should be on the medicine, maybe they shouldn't because it acts differently in women. So again, things are getting better. They're not great sometimes, but they're so much better than when we had nothing.
That's right. We're moving forward.
That's right.
We're moving forward. We're just going to keep going, keep learning.
That's right.
And women are pretty resilient, considering
they are.
how
They're
much
tough
we've
little
done.
characters.
Yeah. So how far we've come. We're still
That's
here,
right.
and even though we haven't been studied, and we just keep trying stuff.
That's right.
Yes.
Yeah.
So how much does childbirth affect menopause? Does it?
Oh, I probably only think about it as, some of the pelvic floor, if you deliver a baby vaginally. I used to say a watermelon through a keyhole. It's a problem.
And my baby weighed 11 pounds, 3.5 ounces,
and that's
so I can relate to that.
And we also know just pregnancy in general and the tissues. In Brazil for a long time, if you had money, you had a C-section because they did not want anything prolapsing afterwards, no damage to the vagina. And they had like a 90-some%. And I remember going to a meeting and they said, everybody was like, oh, you shouldn't do any C-sections, too many C-sections. And then I hear that and they say, everybody should be a C-section. I'm like, how, we deliver them through the belly button or something? What is the deal? But so it can affect tissues because even those ladies with their C-sections had changes, and some would have some stress incontinence when you leak, when you cough or sneeze and stuff like that. So we learned it's just being exposed to the pregnancy hormones can make a difference. If you haven't ever had a baby, it's increased risk for breast cancer. But you have to look at those because if this is a patient who was obese and had and never ovulated, so she never was pregnant, her risk factor is not her age, but it's her obesity. Our BMI is our risk factor for cancer of the uterus of the inner lining, which is the most common, and it's because we have extra estrogen from the fat cells. Now, it doesn't seem to help them that much with menopausal symptoms, but it does raise their risk. And they have the double whammy. You have more estrogen, and you have less ovulatory protection because you're not ovulating. So it's called unopposed estrogen. So you have to really be careful for folks and really talk to them about it and think of things. And that's true as they get older, too.
And as people come to you, what is the most common... is there one common symptom that makes someone come in and say, okay, it's time to come see you, or I don't know what's going on, I don't feel myself? Is there one common
No,
thing?
it's kind of a constellation, and not everybody has everything, but a lot of it is fatigue, fogginess they talk about, and I think that a lot is sleep deprivation, but it's just fogginess they can't function like they have. They're not as sharp as they had been, and they're unwilling to say, oh, it's my age. And I think you should never say it's my age because you should always make sure nothing else is going on. Now, maybe when you're 85, you could say it's your age, but I don't think even then. So I think hot flashes, poor sleep, libido issues, that's a big deal. And the testosterone for some women is a big deal. Now, others don't miss it. So, and then, it's also a relationship kind of thing too, because lives change. Everybody has illness. Maybe your partner has diabetes or high blood pressure, that kind of thing. So it changes things. Okay. So I think it's all those things, and it can be just one. Yeah. But you can fix them. You can do things about it.
You can do things about it. That's a good thing to wrap it up on. All right. Well, thank you so much, Dr.
Well, thank you very much.
This is very helpful, talking about, I think, about whether, mental health can affect menopause and how menopause affects our mental health. So hope you come back. Let's talk next time maybe about things we can do to just keep forward thinking and get out ahead of that mental health and menopause.
That'd be wonderful.
Thank you so much. Always a pleasure.
Thank you.
And everyone, thank you so much for joining us. You can download a new episode of these discussions every other Wednesday morning wherever you listen to podcasts, and we'll meet you right here next time on DocTalk.